Yes. My great is our Batterham. Rachel is a international medical. She's an honorary professor of obesity, diabetes, and endocrinology at University College London. I don't know. In 2020, she was awarded. Thank you. Thank you so much. Thank you. In 2022, Professor Rachel was awarded the honor of Officer of the Order of the British Empire by Her Majesty Queen Elizabeth for her services to people affected by obesity. Her research has played actually a critical role in gut hormones being developed as treatments for obesity. Professor Rachel is passionate about reducing the stigma that people with obesity experience and ensures that patient voice is heard and established a charity for people affected by obesity, which is Obesity Empowerment Network UK. We will hear her speak this evening about obesity beyond BMI.
Thank you. Thank you. Thank you for the kind introduction. So I'm going to say at the beginning, this doesn't mean we're getting rid of BMI. It means that we're thinking of BMI and something else. So here are my disclosures. As you've heard already, I currently work for Eli Lilly, but this talk is separate from that and is not the opinion of Eli Lilly and Company. This is my own personal opinion that I'll be giving to you today. So, definitions of obesity. We've heard quite a lot of those today because there are many different definitions. This is my particular favourite. So this is from the Canadian Medical Association. Obesity is a prevalent, complex, progressive and relapsing chronic disease characterised by abnormal or excessive body fat that impairs health. Now, how does it impair health? And we've seen this figure used by several speakers already. So obesity impacts on every single organ system in the body. And it's the cardiometabolic complications that have the greatest impact on health. So if we think about type 2 diabetes, fatty liver disease, cancer, infertility, to name but a few. But then there's also the mechanical impact of obesity, and this is usually what causes patients to seek assistance. So we end up with urinary incontinence, we end up with reflux, we end up with impacts on the joints and poor physical functioning. And then we also have the psychological and also increased anxiety and depression that come with obesity, and this is a bit of a two-way street with both contributing to each other. But most importantly, obesity leads to premature death. And I think we forget that sometimes. This is a disease that actually kills people. And it's estimated about 4 million people a year, but actually if you think about all the complications, it's probably much greater than that. So what is obesity? I've said already it's excess adipose tissue. And I'm going to spend the next few slides really talking about the adipose tissue, because this is what's driving obesity as a disease. So we need to store excess energy in order to survive. And excess energy is stored in adipocytes as triglycerides. And as we have excess energy in, then the triglycerides either increase in number or they increase in size. But adipocytes are highly biologically active, and they produce a myriad of factors which then control immunity, inflammation. And when these adipocytes start to grow, then you end up with lack of oxygen, so you get hypoxia, you get death of adipocytes, and then you get inflammation and migration of macrophages and T cells into the adipose tissue. And this is what drives the systemic inflammation. And this chronic, low-grade systemic inflammation then drives the cardiometabolic complications of obesity. So this is all due to adipose tissue. So you can expand your fat and not put it in the wrong place. So this is healthy adipose tissue expansion. So there's no spillover into other organs. And then there's something called adipopathy, sick fat, which is when you end up with spillover into the liver, into your visceral organs, around your heart. And this causes a very different type and the cardiometabolic complications. So we have an effect from the fat mass per se, but then we also have an effect when the fat mass is not handling the adipocytes and you get spillover into the different tissues. So if we think about obesity from an adipocyte, an adipose tissue perspective, we need to think about the amount, the function, is it functioning normally or have we got adipopathy, and also where it's located. So we have a fat mass effect, so even if that fat mass isn't adipopathy, but this still has a mechanical effect leading to disease. But then there's also the sick fat disease, which is where we're seeing the cardiometabolic complications. So having said that obesity is a disease of adipose tissue, then how do we define obesity? So at the moment, we're using body mass index to define obesity. This is a WHO classification, and these cutoffs vary in different regions depending on ethnicity. So where does body mass index come from? The picture is not supposed to be over the words. So it was basically originally called the Courtelet index because it was designed by a Belgian mathematician in the 1830s who was looking at the relationship between weight and height. So it was originally called the Courtelet index. And it wasn't until the 1930s that then it became reclassified as body mass index, actually 1972. I needed it not covered. So in 1972, then it was then renamed as body mass index. And then NIH in the 1980s then started to use BMI, and they looked at BMI cutoffs in Americans and then started the classification that we currently have of underweight, normal weight, class 1, 2, and 3 obesity. And then the WHO in 2000 then adopted BMI. So this is where BMI came from. So it originally came from a Belgian mathematician. So the advantage of BMI, it's easy to do. Anybody can do it. It's at simplicity and also easily accessible. Quick, cost-effective, and also the public now understand BMI. It's used widely, so you can use it for population studies, and you can compare in different regions. And it is associated at a population level with risks. So if you look at BMI and you look at risks of type 2 diabetes, cardiovascular disease, at a population level, then it is very good at picking those up. So it's a useful first step in identifying individuals at risk of obesity-related health issues. And I've already said it's very useful at a population level. And if we look at a plot of body fat mass versus BMI in men and women, then we see there's a good association. So that's why it's been used. But what are the disadvantages of BMI? So obviously it doesn't distinguish the weight, whether this is fat mass or whether it's lean mass. So as a result, muscular individuals can be diagnosed as having obesity when they don't. And conversely, people who have sarcopenic obesity, who have increased fat mass but low lean mass, are not diagnosed of having obesity because it's not looking at different composition. It gives you no information on where the fat is located, which is really important. And it doesn't factor in ethnic or gender variability, and it also doesn't factor in that we know that as people age, then your body composition changes. Unfortunately, all of us, as we get older, lose our lean mass and increase our fat mass, even if our weight stays the same. We can try very hard to change that with lots of exercise, but it's very difficult to do. So this schematic just shows you part of the issue with BMI. These two caricatures have the same BMI, but as you'd say, the person on the right of the slide has got obesity, whereas the person on the left of the slide is a muscular, fit person. And this often leads to headlines in newspapers. So this was one of the classic ones from the UK saying that 1 in 3 Rugby World Cup players have obesity. We haven't quite trained the UK press to use person-first language yet. And the location really matters. The same way that it matters where your house is located, location, 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 where the adipose tissue is located is really important. So this shows an MRI of adipose tissue around the heart. Epicardial fat has a really negative impact on cardiac function. And then we have subcutaneous fat and then visceral fat encasing the internal organs. So how can we improve on BMI? So one of the other easy things you can do is waist circumference, which is a measure of central adiposity. I've got another slide that shows you how to do this on the next one. And the other thing to say is waist circumference is of limited value in somebody with a BMI of 35 or more, because we already know if they've got a BMI of 35 or more that they've got increased cardiometabolic risk. Where it's really useful is when you've got people with BMIs in their 20s and you're trying to work out, do they have excess adiposity? But also when you've got somebody who's muscular and you're trying to work out, do they have excess adipose tissue? So it's a simple measure to do. And it's strongly correlated with visceral adipose tissue, which is an increased marker, a risk factor for type 2 diabetes and cardiovascular disease. So how do you measure it? You find the bottom of your ribs, the top of your hip bone, and then you pull. I should have brought a tape measure up, shouldn't I? And then you put your tape measure round. You don't pull it tight. And it sits usually just above your belly button. And the cutoffs for this vary depending on gender and ethnicity. So NICE in the UK spent a lot of time trying to decide what other anthropometric markers should be measured in the UK in standard clinical practice. And having looked at all the data and lots of different ethnicities, they have recommended that we use weight to height ratio. Now, the beauty of this is the cutoff is the same in men, women, children, and all different ethnicities. So if your waist is more than half your height, then you're at increased risk. And this has been actually publicized to the public. I mean, the public have been asked to do this. Even if they take a piece of string, measure their height, fold it in half, if it doesn't fit around their waist, then they should be worried about their waist circumference and discuss it with their healthcare professional. So this is NICE recommendation. But if you want to do more sophisticated body composition, then we can do bioimpedance. Yes, there's a lot of debate on how accurate BIA is, but it's increasingly used in many obesity clinics. DEXA scanning, which again, depending on which country you're in, is used more or less. But actually within the UK, DEXA is used quite a lot to look at body composition, but mainly in research settings, but could be used a lot more. We use it to look at bone density. We should be thinking about it more in the context of body composition. And then obviously MRI scanning, which has its issues because a lot of patients can't fit in the MRI scanner because of the actual girth of the MRI scanner. And then there are other ways of thinking about obesity. So this is the Edmonton Obesity Staging System, designed by Arya Sharma, who spoke to you earlier today. So this is looking at medical, psychological, and functional aspects of a person. So looking at the impact of their excess adiposity on their functioning. And then basically you stage these three different attributes, and the staging system is the highest score that you have. So if in the medical you score a 4, then your Edmonton Obesity Staging score is 4. And again, this is used routinely in many clinics for bariatrics and becoming more common in medical clinics as well. And why is the EOSS or EOS score so good? Is it actually predicts mortality. So on the left-hand side, this is the NHANES data showing you that BMI doesn't really differentiate that much the people at greatest risk of dying. Whereas if you use your EOS score, then you can see there's a real separation, and it really identifies people who are at the greatest risk, which in a constrained healthcare system is often where we need to focus our initial efforts. And then EASO, they recently brought out a new framework for diagnosing, staging and managing obesity in adults. And again, this has an anthropometric component, so it's BMI, and again, they are recommending waist to height ratio in people within the lower BMI range. So not just BMI, BMI plus a marker of where your adipose tissue is. And then there's a clinical component, again, medical, functional, and mental. I prefer the word psychological, but that will do. So, but there's still a huge amount of resistance by many governments and policymakers to recognise obesity as a disease, and also by the public. There's always people saying arguments for, we're medicalising obesity, and also arguments against why obesity should be recognised as a disease. And in the UK government don't recognise obesity as a disease. The Royal College of Physicians do, but the government have said at the moment, based on BMI, they won't recognise it as a disease. So part of the problem is obesity is both a risk factor and also a disease. And when is it one and not the other? So what is a risk factor? A risk is it's likely that something will harm. So it's a possibility, it isn't a given. So if something's a risk factor, then it's a possibility that it's going to do it. Whereas a disease is different. It's a condition of a person in which the body is harmed because of an organ or part that is unable to work as it usually does. So this is when there's an illness. So when is obesity a risk factor and when is it an illness? So again, risk factor, this is from the WHO. So the WHO have a definition for obesity as a risk factor. So abnormal or excessive fat accumulation that presents a risk to health. A person with a body mass index over 30 and is defined as having obesity. So this is when the WHO say it's a risk factor. But then they also say it's a disease when abnormal or excessive fat accumulation is associated with specific signs or symptoms and reduces ability to conduct day-to-day activity. So the WHO call it both. So far, the current definitions of obesity are based on BMI. And whilst they're useful epidemiologically, they're flawed at the level of the individual, because they can either over or underestimate illness. So we need a definition that recognises when adiposity is causing illness and when it's not. And this should be, hopefully, prevent people being labelled as sick or having a disease when they don't. But it also help people with a normal BMI who have excess adiposity to receive the normal treatment. So in order to try and address this problem, the Lancet Commission was established. So this is made up of 56 obesity experts, and it covers all fields of obesity. So academics, scientists, public health specialists, patient representatives, which is really important, because we need the patient voice in this. This can't just be a load of HCPs deciding. You need to get buy-in from patients. And also WHO officers. This is a list of all of the commissions and very globally spread to make sure that we've got people from low-income countries and also high-income countries and spread across the world. Now, can you imagine getting these 56 people to agree? So this is partly why this has taken such a long process, because if you put 56 academics in a room and try and get them to agree, it's quite tricky. But what was the aim? The aim was to define clinical obesity and identify objective criteria for its diagnosis. So this is similar to other medical specialties where we have a proper sort of diagnostic criteria where we can say, does somebody have obesity as a disease or as a risk factor? So this sort of schema summarises sort of where the Lancet Commission is going. So we know the causes of excess adipose tissue expansion, then we have obesity, and then we have, is it causing an illness or is it a risk factor for the other diseases? So how did this work? So there were monthly meetings, and then there were 8 subcommittees that were set up. Genetics and pathophysiology, clinical signs and symptoms, impact of obesity on health, children and adolescents, so this also covers children and adolescents, patient perspectives, then focusing on the ethnic-specific cut-offs, because we can't just think about Caucasians. Most of the people in the world affected by obesity are not Caucasian, so we need to make sure that we're thinking about other ethnicities. Delphi questionnaire, because that had to be designed, a writing group, and then a communication group. So what happened? So there are lots of webinars, and people in this room participated in those webinars, looking at Donna Ryan, where we discussed various aspects, and there was external presentations, and then a pre-Delphi online survey. And then there was a Delphi consensus, which involved 3 rounds of trying to get the, what everybody was putting forward to agree to. Then there was feedback, so that what we were putting out then went to professional organizations globally, and also to patient societies, to make sure that this resounded with them and they were happy with what was going in it. Then there was a report preparation, and then the report is going to be published on the 14th of January, and the big launch, which will then communicate this globally, will be on the 16th of January. So if you look at the timeline, this has taken a long time. So the conception was in 2019. We started the commissioners in 2021. The report was submitted in December 2023 and went through an extensive peer review period. And it's accepted and is due to be published in January 2025. So what will it do? So this, again, just covers the whole thing. So we have primary prevention. So primary prevention should be focusing on what we know is driving obesity. This is where your food labeling is going to come in, is important, and really thinking about primary prevention. Then we have obesity with preserved health. It doesn't mean that these people with excess adiposity we shouldn't do anything with, but we should be monitoring and doing prophylactic intervention in those people. But then the people that we really need to focus on are the people with clinical obesity, where obesity in them is actually a disease and not a risk factor. And why do this? Well, at the moment, many governments globally do not know how to even start to address obesity. The problem is too big. They're like, where do we start? Who do we treat? Who do we start with? And this provides some context as to where obesity is in itself a disease. And that's where initially we should be focusing our efforts in terms of therapy. So take-home messages. You know the first bit. Obesity is a chronic, progressive, relapsing disease, but it's due to excess adipose tissue. And we need to be thinking about the adipose tissue, where it is, the amount of it, and get far more sophisticated than just doing BMI. BMI is good as a screening tool, but that's all we can use it as. And we are missing some of the people who have obesity at a lower BMI. And we really need to think about where the adipose tissue is located. As I've said already, obesity is a risk factor and also a disease in its own right. And the term clinical obesity is when obesity itself is a disease. And the overall aim of this is this should really help get around the debate of obesity being a disease, because the Commission has got specific criteria looking at different organ systems as to help people sort of stratify whether obesity is a disease or a risk factor. And I'm sorry I can't share the results with you already, but please, when it comes out in January, really think how you can incorporate this into your clinical practice. And even now, start thinking about adding in waist to height ratio, or just doing some additional measures as we go forward. Because when we're treating people with obesity, we need to know what we're doing to where the adipose tissue is located. We need to think far more about body composition and the impact on health, and try and get away from just looking at weight, because it's all about improving the health of the person, which is related to the adipose tissue, and not just the weight on the scales, which is where we're focused at the moment. Thank you very much for your attention.
Thank you very much, Dr. Rachel. Do we have any questions? Dr. Nina.
Thank you, Dr. Rachel, for the wonderful talk. I do use waist circumference a lot in my clinic, but some of the challenges I face is patients who do tummy tuck procedures or do liposuction for subcutaneous fat. Is there any harm to doing these procedures if we're only targeting the waist to height ratio or just a waist circumference in the long run? Especially if this is not somebody who's obese clinically, but more like overweight.
So I guess it sort of depends on sort of the BMI of your patient. So I say it's most useful in people who have more in the sort of BMI 23, 24, who actually we probably don't see because they're not getting picked up of having obesity. Waist to height, the impact of tummy tucks on that, I'm not sure, to be honest. But I think one of the things is actually looking within person as the changes in response to treatment.
Thank you. Thank you so much. Very interesting talk, Rich, as ever. But looking at adipose tissue, to look at a reliable parameter is very difficult. We look at children, adolescents, young age, middle age, elderly population. The fat distribution is different from with age. That's one point. The other thing is, when you get in the clinic a patient in a wheelchair or a patient with kyphosis or scoliosis, then it's very difficult to judge the stage of the obesity.
No, I agree. And I think in those sort of groups, again, we need to come up with guidelines as to how we do this. And the problem is at the moment, it's difficult. So because it's difficult, everybody just sticks with BMI. But I think as we go forward, we need to get more sophisticated. What other speciality does no tests? If you think every other speciality measures things in a more objective way to look at the actual tissue that's causing the disease, whereas at the moment with obesity, we just seem happy to just do weight and BMI. So it's just, how do we evolve that? And also, one of the things of the Lancet Commission is it really does give you a framework for holistically assessing every single organ system in the body. So again, it helps with thinking holistically that we think about the whole patient rather than just one little bit. But I agree, it's how we measure adipose tissue, whether any of the new apps that basically you can scan your body, use your phone and scan your body, take a picture. There's a lot of work going on to see whether those apps are actually validated when you start to look at body composition by other means. But from my perspective, I think that's the sort of way that we're going to go, because everybody in the world has a smartphone. Whereas if we can't do DEXA scan on everybody, but what we can do is use DEXA and these new applications using AI to actually validate them and then move forward. But we need to do something.
Any other question? I have a question, actually. And it follows actually on the last question that Dr. Sarah had to answer. Given that we prescribe pharmacotherapy for our patients with a BMI over 30 or BMI over 27 plus 2 comorbidities, do you believe we will eventually prescribe it based on other measurements of fat mass versus lean mass?
It's going to take a while, because obviously that means proving that these are related to outcomes. So when we go to regulators, they'll want to say, well, if you want to look at fat mass, is that more relevant in determining future health problems than weight? So we need to generate the body of evidence, and it needs to again be specific to the population. So